Good afternoon, dear students. Our today topic is meningeal syndrome in clinic of infectious disease and meningococcal infection. Meningitis is inflammation of meninges of brain and spinal cord. Acute meningitis plays a leading role in infectious pathology of central nervous system. Classification of meningitis may be by following criteria: by appearance, primary and secondary meningitis. Primary meningitis occur without any preceding infection or local inflammation as independent disease, and secondary meningitis would occur as a result of complication of general or local infectious process. Examples of primary meningitis: there are rich group of primary viral meningoencephalitis, tick-borne encephalitis, for example. Example of primary bacterial meningitis: meningococcal infection, one of clinical form of it, may be realized in form of primary meningitis, meningoencephalitis. As example of secondary meningitis, there are meningitis what may be associated with sepsis, TB meningitis as complication of primary process in lungs, may be a meningitis in case of rich amount of diseases what associated with bacteremia, such as typhoid fever and some other infections. Next type of classification according to etiology, and we may describe bacterial meningitis, viral, fungal, spirochetosis, rickettsial, protozoal, helminthic, and combined form of meningitis. Mostly in clinical picture, of course, suspected bacterial and viral meningitis. Less rare rickettsial meningitis in case of severe immunosuppression. Fungal meningitis, and rare but not connect with immunosuppression, spirochetosis meningitis. As casuistic, as very rare cases, maybe this we may speak about helminthic meningitis, and in tropical countries may be suspected protozoal origin of meningitis. By type of inflammation and change in cerebrospinal fluid, of course, more famous type of classification, what like students of every part of the world: serous and purulent. In case of serous meningitis, will prevalent lymphocytes. In case of purulent meningitis, will prevalent neutrophils. By duration of course of disease, we may speak about acute meningitis, more often form, lingering form, and chronic. By severity, mild, moderate, severe. Classical subdivision for 3 degrees of severity. Encephalitis, polyetiological disease of infectious, often viral or infectious allergic origin, characterized with inflammation of the brain or spinal cord, accompanied with cerebral and encephalitic syndrome, increased intracranial pressure, and inflammatory change in cerebral spinal fluid. Pathogenesis for different kind of meningitis, meningoencephalitis, include first of all entrance gate for causative agent. There are, due to rich amount of diseases what may provoke meningitis, meningoencephalitis, they are very different. For meningococcal infection, first of all respiratory tract, nasopharynx. For some infections, it may be intestine or through the skin, but in each case, after primary multiplication in entrance gate, will be dissemination of pathogen, what may be realized through the blood, hematogenic, hematogenic way of dissemination, may be lymphogenic way of dissemination, and may be contact way of dissemination. There are three pathogenetic factors play an important role in development of disease. Practically each meningitis, meningoencephalitis especially, these three factors play significant role in case of meningococcal meningitis. First of all, bacteremia, second, toxemia, and third, microorganism initial immunity. Due to the destruction of gram-negative microorganisms will be releasing of endotoxin, and due to it appear realization of bacteremia and toxemia too. Toxemia provoke increased level of biological active substances and products of disturbed metabolism. Result of it, increased permeability of cellular and vascular membranes, blood-brain barrier. Result of increasing permeability of brain capillaries will be active penetration of bacteria and toxins in central nervous system with development of pathological processes. And second, may be realization of brain edema. Realization of brain edema. Irritation of vascular due to previous facts will be realization of irritation of vascular plexus of brain ventricles with bacteria, antigens, toxin, and immune complexes. And due to this irritation will increase cerebrospinal fluid production and will rise intracranial pressure. Irritation of structure of the encephalic region, centers of thermoregulation, vomiting, vascular center cause the main clinical manifestation of disease, such as headache, repeated vomiting, and meningeal symptoms. The complex of symptoms of acute meningitis consists of four major syndromes. First, general intoxication. Third, meningeal syndrome. Second, cerebral syndrome. And fourth, syndrome of inflammatory changes in cerebrospinal fluid. General intoxication include common signs what very like to describe student. Here will be acute onset with fever, appearance of febrile fever, paleness of skin, chill, weakness, anorexia, tachypnea, dyspnea, tachycardia, dullness of cardiac sounds, change of heart rate, unstable blood pressure. Cerebral syndrome include headache, what will be strong, diffuse, sometimes local, but mostly strong and diffused, increased with change of body position due to high intracranial pressure and irritation of pain receptors of pathogen, pain receptors with pathogen. Next sign what include in cerebral syndrome, vomiting, what has central mechanism due to direct irritation of vomiting center. Vomiting will be repeated, occur suddenly and without previous nausea. Does not bring relief and may be increasing of vomiting when change body position. Possible disturbance of consciousness from agitation, from exaltation to sopor and coma. It will associated with development of toxic damage or with development of brain edema. Will be suspicion of seizures. from twitching of some muscles to generalized convulsions and convulsive status. Expansion of veins of head, eyelids, and eyes. Meningeal syndrome. Meningeal syndrome developed due to irritation of cerebral and baroreceptors by high liquid pressure, or due to irritation of these receptors with viral bacterial toxins. Several clinical signs include in this syndrome, and all of them may be subdivided for 4 groups. First group of signs, the group of tonic muscle tension. There are signs what, like students of every nation, every part of the world, when students try to describe meningeal syndrome. And standard answer usually include rigidity of occipital muscles, Kerning sign, Brudzinski signs, and after that, that's all. But I'm very sorry, there are only first group of signs what associated with meningeal syndrome. Description of these classical signs of meningitis you may suspect on this slide. For example, rigidity of occipital muscles. Its passive flexion of patient neck is difficult or impossible. Kernig signs and Brudzinski signs you may suspect here too. Next, what include in this group of tonic change the position of patient, so named meningeal position, position of setter dog, trigger pose. This photo with this position of the patient will be a little after. You may suspect this pose of patient on this small photo, but after will be more big photo of patient with meningitis. Second group of signs what include in meningeal syndrome signs of general hyperesthesia. There are photophobia, hyperacusia, and other signs of hyperesthesia due to irritation of posterior root cells of spinal nodes, receptor of meninges, and a decreased level of sensitivity to various actions. Third group, reactive pain phenomenon. There are Bechterew sign, Labzin sign, Kerr sign, Pulatov sign, Mendel sign, and practically that's all what include in reactive pain phenomenon. For example, Mendel sign, pain when you press on the frontal wall of the external ear channel. Patient feel strong pain. When you make percussion of a scalp, patient may feel strong pain. Labzin sign, patient feel pain when you press on when you little press on the eyeballs. There are reactive pain phenomenon. Fourth group of sign, changed of dermal perio and tendon reflexes, appearance of pathological reflexes. There are Babinski reflex, Appengame, Rossalima reflex. There are physiological reflexes for children, for newborn children, but there are pathological reflexes in adult. And last group of signs what include what include in meningeal syndrome. It's signs of inflammatory change in cerebrospinal fluid. Practically, for differential and etiological diagnosis, very difficult to describe situation when you make to put diagnose without mistake, without previous analysis of cerebrospinal fluid. Etiological diagnosis of central nervous system infection is very important because without etiology you can't to use normal etiotropic therapy, and of course without adequate etiotropic therapy, prognosis for the patient will be not very fine. Maybe fatal prognosis if you treat, if you think about viral meningitis and treat patient with antiviral remedies, but in patient really on autopsy was revealed bacterial meningitis. So due to it necessary to know about typical changes in cerebrospinal fluid, and of course necessary to know normal indexes of cerebrospinal fluid too. Inflammation of meninges is accompanied with following changes in CBC. First, increase in pressure. Cerebrospinal fluid is flowing extremely or with frequent drops. Change in transparency or color. Pleocytosis with domination of neutrophils or lymphocytes or mixed. Increased level of proteins, change of level of glucose and chlorides. What I propose to you when you try to analyze situational tasks or you wanted to decide tests about cerebrospinal fluid, first of all, look on level of sugar. It's the deciding of question about viral or non-viral etiology. In case of non-viral etiology, sugar level usually decreased. In case of viral etiology, sugar level will be stable. Next, what necessary to check? Level of proteins and chlorides. A level of proteins and chlorides give for you answer present inflammation or absent. And, and last position, analysis of cells what's prevalent in cerebrospinal fluid. This order of checking for cerebrospinal liquid, analysis of cerebrospinal liquid will give for you less quantity of mistakes. So type A of change for cerebrospinal fluid, typical bacterial meningitis, prevalence of neutrophils, counting of neutrophils, thousands cells in milliliter, typical for bacterial meningitis. Sugar level decreased, less than 50% of blood concentration, and typical purulent process. I can't to say that possible to add here something. Type B, slightly tubed cerebrospinal liquid, quantity of cells 100 cells, not so significant rising of common level of leukocytes. Practically, this type this type of change in cerebrospinal fluid are typical for granulomatosis meningitis, for TB, for mycotic meningitis. Look, in case of TB meningitis, may prevalent mononuclear lymphocytic cells, polymorphic cells will be less, and it may stimulate appearance of mistakes due to what we know well, that in case of bacterial meningitis, most prevalent neutrophils in this cerebrospinal fluid prevalent mononuclear cells, and you may start think about viral origin of this situation, but no, look on level of sugar level less than 50% of blood glucose concentration. It does mean that sugar was used in time of life of some bacteria what come to the central nervous system. Because sugar is necessary for survival of bacteria. Due to it, for type A, for type B, sugar level will be decreased less than normal. Normal level of glucose in cerebrospinal fluid is 50-60% of blood concentration. Type C of changes are typical for serous meningitis, for viral meningitis mostly, will prevalent lymphocytes, mononuclear cells, protein level will increase, glucose level will be normal. So again, we return to strategy what I described before. First of all, check not cells, but level of protein. Level of protein give for you answer present inflammation or not. Glucose level, answer for the question, is it possible viral etiology or not viral if sugar level decreased. On next slides will be the normal level of different indexes in cerebrospinal fluid and comparing of with normal level with different situations. First pair what described on this slide, meningism. Meningism, it is situation when in patient suspected irritation of meningia, but inflammation is absent. Why it appear? Due to increasing of intracranial pressure. What may increase intracranial pressure? There are a lot of reasons. Tumor, brain edema, trauma, intracranial bleeding, stroke, and other reasons when we may toxic damage, when we may suspect meningitis-like syndrome. Signs of meningitis present, but changes in cerebrospinal fluid practically absent, especially absent inflammatory changes. And look, level of protein is practically normal. Level of sugar not changed. Level of cells not changed. Serous viral meningitis. serous bacterial meningitis. Example of serous bacterial meningitis, there are TB meningitis, leptospirotic meningitis, and some other infections. So what interesting here? In case of serous bacterial meningitis, will decreased level of sugar. First of all, cells will be same level of cells. Pressure must be more for serous bacterial meningitis, but practically for serous viral level of pressure increasing may be practically same. Objective in 30-40% will be suspicion of fibrin films in glass what contain cerebrospinal fluid after taking of it. But what necessary to remember, these fibrin films not appear in one moment. It will appear after several hours after keeping in refrigerator. So it will not fibrin will with fibrin films for checking for it necessary to wait around 24 hours. So first of all, again, level of sugar, level of protein, and after that, analysis of cells. Purulent hemorrhage. For hemorrhage, of course, will be differential diagnosis between purulent meningitis and hemorrhage. Here, differences are very bright, different color. Of course, blood color in case of hemorrhage. Different cells, because in case of meningitis will prevalent leukocytes, in case of bleeding will prevalent red blood cells. Level of protein increased in both cases, but glucose level of course will be different in case of meningitis due to activity of bacteria. Level of sugar in patient with meningitis will fall in cerebrospinal fluid. In case of hemorrhage, level of sugar of course will be normal. More often variants of primary purulent meningitis are meningococcal, pneumococcal, Haemophilus influenza. Secondary purulent meningitis develop as complication for sepsis, diseases of different internal organs, ANT organs, for example, otitis, mastoiditis, sinusitis. Result of pulmonary infection, result of generalization of infection in case of pyelonephritis in immunosuppressed people, and more often produced with staphylococci, streptococci, and other variants of pathogens. Diagnostic criteria for primary purulent meningitis for meningococcal meningitis: acute respiratory infection, anthraponosis with aerogenic mechanism of transmission, pathogenetically characterized by destruction of respiratory epithelium, clinically intoxication, rhinopharyngitis, affection of central nervous system, and sepsis-like state. In anamnesis, winter, spring, seasonality. Now, is very difficult to say about prevalence, but usually like more cold condition. Route of transmission: airborne, source of infection: sick human. Any form of meningococcal disease may be dangerous. And of course, in epidemiological significance, more dangerous carrier state, then patient don't know that he is maybe dangerous for other people. Risk group: children under 1 year, very old people, and people with different kinds of immunosuppression. Every 8-10 years rise rate of this infection. Duration of of infectious period 3-4 weeks. And patients are infectious during prodromal stage and acute phase of disease. For today, mortality of meningitis, it's one of clinical form of meningococcal infection, is around 3-5%. Mortality of meningococccemia, it is one of more dangerous form of this infection, up to 20%. Causative agent belong to Neisseria meningitis. Characteristics of it you may suspect on these slides. Small gram-negative diplococci, typical location inside the cells look as pair of coffee beans. Don't formate spores, non-motile, aerobic, obligate intercellular microbe, very sensitive to action of antibiotic, very sensitive to disinfectative solution, non-stable in environment. So very gentle microorganism. Due to eating group of risk, first of all, children, because parents or other family members may be in carrier state for this infection, and who in our population have more soft contact. Of course, family members. Distance for effective spreading of this kind of microorganism is less than half meter. Who come to us less than half meter? Usually family members. And of course, sometimes other people. No? Here, slide photo of these microorganisms under microscope, coloration by Gram, and this deep blue, practically black microorganism. There are diplococci inside the cells mostly. Here, diplococci inside cells may be suspected too. Pathogenesis of meningococcal infections are subdivided for 3 stages. First stage, penetration. This stage may be described as local forms of disease. Maybe suspicion of nasopharyngitis or pneumonia or carrier state. In some people, not at all. For most part of people, process may be finished with local form. But in people who have immunosuppression, it may be situational immunosuppression due to supercooling, due to stress, due to other factors. Will be realization of bacteremia, infiltration of causative agent in blood, with following lysis of bacteria and releasing of endotoxin, and disease proceeds as acute sepsis with hemorrhagic rash and hemorrhagic syndrome. In this situation, suspected meningococccemia, but may be a not so acute form of disease, but maybe distribution into the brain with hematogenic way, lymphogenic way, perineurally, and through etmoidal bone. And due to it, inpatient may realizated meningitis. Pathomorphology associated with acute inflammatory response in place of implantation of causative agent. Result of releasing of endotoxin is diffuse vasculitis and realization of DIC, disseminated intravascular coagulopathy. Classification of meningococcal infection. First of all, a localized form. To localized form belong carrier state. Without clinical manifestation may be revealed only bacteriologically. Second clinical form, nasopharyngitis. Third, meningococcal pneumonia. There were localized forms. Two generalized forms belong meningococcal sepsis, meningitis, meningoencephalitis, mixed variant, meningococccemia plus meningitis, and unfrequent form of disease such as arthritis, endocarditis, otitis, and others. Mostly realization of generalized form, it will there were meningitis, meningoencephalitis, or meningococccemia, meningococcal sepsis. Clinical picture. Very acute onset. Very fast rising of body temperature to 38-40 degrees Celsius. Expressed intoxication and appear meningeal signs. Previously, 2-3 days before, in anamnesis in patient may be revealed signs of nasopharyngitis. So what will be? Will be headache, repeated vomiting, not bringing relief, may change level of consciousness. In severe cases will be generalized convulsions, disturbance of level of consciousness. Meningeal syndrome appear may appear in the first day of disease, not only after 2-3 days of nasopharyngitis, and may have different severity. One of typical complication is brain swelling, if edema swelling of brain. In 1-2% of cases of patient may be revealed signs of encephalitis with paralysis, paraparesis, disorders of coordination, and other focal symptoms. Will be suspicion affection of cranial nerves, maybe hallucination, exaltation, or SOPA. In 1/3 of cases will be combined form meningococccemia plus signs of meningitis. One of bright clinical signs of meningococccemia is hemorrhagic rash of the skin with petechial characteristics, sometimes up to 15 centimeters in diameter, with necrosis in center. Typical distal location of this rash, distal part of extremities, first of all, and very often meningococccemia, meningococcal sepsis associated with serious and severe complications. First of all, infectious toxic shock, DIC syndrome, syndrome of Waterhouse-Friderichsen, development of endocarditis or pericarditis, and other possible fatal complications. In CBC will be suspected leukocytosis, neutrophilia, shift to the left. In cerebrospinal fluid will be findings what typical for type A of change of cerebrospinal fluid. I repeat, will be decreased level of sugar, rich amount of neutrophils, more than 1000 cells in 1 milliliter, and significant rising of proteins. As fast method of diagnostic of meningococcal meningitis may be microscopic examination of cerebrospinal fluid with coloration by Graham, and in smear of cerebrospinal fluid may be revealed gram-negative diplococci what placed intracellularly. In case of meningococcemia, as fast method may be used of microscopic examination of thick drop of blood. Additionally, will be used bacteriological examination of swab from mucous membrane from nasopharynx. Maybe obligatory will be used bacteriological examination of cerebrospinal fluid, of blood, and it will play the leading role in diagnosis of meningococcal infection. Supportive significance has serology. Due to what? Very acute form of infection. If you think that in first, second day of disease, titer of antibody will rise to diagnostic level, to diagnostic titer, it is wrong thinking. In first day, titer of antibody may be lower, and due to it, you will need to repeat serology after 3 days or 1 week. For so acute infection as meningococcal, it is not very good choice to wait so long time. First of all, usual microscopic examination with coloration by Graham to make films from all possible places: airways, blood, cerebrospinal fluid. Second step, to wait results of bacteriological examination. Primary result of bacteriological examination will be after 24 hours. Final result of bacteriological examination usually will be after 72 hours. So it may be more effective, and parallelly with it, you may check level of antibody to Neisseria meningitidis in patient with possible meningococcal infection. Clinical manifestation of less severe nasopharyngitis, practically nothing interesting. Same with flu. Moderate headache, fatigue, dry cough, some pain in the throat, uh, and mostly subfebrile. Mild severity, practically mild degree of severity in these cases, 95%. To moderate degree of severity with body temperature more than 38 degrees Celsius belong around 5% of patients. So very rare then nasopharyngitis demonstrate aggressive form aggressive characteristics for this stage. General duration around 1 week. But nasopharyngitis in case of this infection may precede the meningococcal sepsis in 1/3 of cases. So nasopharyngitis, it is not problem. Problem that it may generalized. Meningococcal sepsis, meningococemia, characterized with acute beginning, chill, fast rising of temperature to febrile level, expressed intoxication, appearance of hemorrhagic syndrome with hemorrhagic rash, enanthema on mucous membranes, on mucous membrane of conjunctiva, hemorrhage on sclera, maybe hemorrhage in joints, and appearance of bleeding due to realization of DAC. So, a typical rash in case of meningococcemia, you may suspect on this photo. Look on the photo of child from the left. First of all, distal location of rash. Look, trunk practically not involved. Extremities maximal involvement. Look on photo. Look for right photo. Black ends of fingers. It is necrosis due to microthrombosis. So again, distal damage more serious than proximal. Examples of typical hemorrhagic rash on these 4 photos. Right in right up corner, rash with necrosis in center, hemorrhagic rash, and in center black spot, it is necrosis. A very good photo in left upper corner. What demonstrate irregular form of rash in case of meningococcal infection. This kind of rash is typical for meningococcemia. This type of rash is typical for meningococcemia with a regular star-like form, sometimes in some textbooks named as star-like form. Example of hemorrhage on the finger, on extremities, result of necrosis in center of rash. Here massive here on the foot you may suspect beginning of rash, rich necrosis of rash at a lower photo, and outcome of this rash, photo number 4. Necrosis of fingers, ends of fingers, distal phalanx is with necrotic changes. Again, extremity with hemorrhagic rash in case of meningococccemia. And again, distal location of rash. Result of this rash. Other signs. Cardiovascular system. First of all, hypotonia, possible development of infectious or toxic shock, tachycardia and dullness of heart sounds. Respiratory system, dyspnea, cyanosis, superficial breathing, dry rales. GAT may be constipation, will be increasing size of liver and spleen, usually not from the first day of disease, of course, but it is possible as compensatory reaction. In CBC, urogenital tract, decreased diuresis, proteinuria, leukocyturia, erythrocyturia as signs of toxic kidney. White blood cells, hyperleukocytosis, increased level of ESR. And necessary to check level of electrolytes, possible decreased level of electrolytes in blood due to total increasing of permeability. So, differential diagnosis must be done with severe influenza, hemorrhagic vasculitis, and different variants of sepsis. But differential diagnosis of different meningitis and meningococcal infection, it is task for the sixth course, and I will not stop attention on this position. Meningitis. If before was description of meningococccemia, meningitis. First beginning of disease. High fever, intensive headache, vomiting, central type of vomiting, signs of hyperesthesia, meningeal signs, damage of cranial nerves. What kind of cranial nerves will be damaged? Third, fourth pair, and 7th, 8th pair. Mostly third, fourth pair will be involved in process. Clinical picture of of meningeal signs we described before, so here practically repeating. What will be suspected? In cerebrospinal fluid, neutrophils more than 1001 microliter, increased level of proteins, decreased level of sugar. On this slide, you may suspect typical position of patient with meningitis, especially with meningococcal meningitis, so named trigger position. Here, a child with meningitis, position of child with meningitis. Here, position of child with meningitis, it may look as this too. Here, physician check of Kernig sign and Brudzinski sign. Here, checking of rigidity of neck muscles. Here, positive lower Brudzinski sign. Position of patient and elements of hemorrhagic rash on extremities, non-extremities. Autopsy. This yellow what cover brain is pus. Very good photo as a result of autopsy in case of purulent meningitis. Here you may suspect pus what cover meninge, so soft membrane of brain. Where it, classical example of very severe meningitis, yellow with greenish, it's again pus. Meningococcal meningitis more often appear due to diffuse damage of brain with disorders of consciousness and focal changes. What will be focal symptomatic, such as oculomotor disorders, different variants of paresis, psychosensual disorders, and aphasia. Complications for all kinds of meningococcal infections, especially generalized. First of all, acute renal insufficiency, superinfection, infectious toxic shock, activation of herpetic infections, realization of secondary pneumonias, otitis, pyelonephritis. There are typical complications. Here on this slide you may suspect paresis of facial nerve in patient with meningococcal meningoencephalitis or meningococcal meningitis. Here result of CT scan, description of this CT scan you may suspect on slide 2. Change of ventricles in case of increasing of intracranial pressure. And we return to laboratory diagnosis. Laboratory diagnosis, first of all, fast methods. There are microscopic examination of smear from mucus of nasopharynx, cerebrospinal fluid, thick drop of blood. What we search? We wanna search gram-negative diplococci, what will placed intracellularly. Biochemical and morphological investigation of cerebrospinal fluid will be necessary for revealing of these bacteria, and may be used immunological tests such as reaction of hemagglutination, reaction of indirect hemagglutination. Diagnostic titer of a hemagglutination test is 1 per 160, reaction of indirect hemagglutination 1 per 200, and may be using of ELISA. On this photo, process of taking of cerebrospinal fluid in patient. This photo is tubed cerebrospinal fluid, purulent cerebrospinal fluid. Examination of cerebrospinal fluid. When we take cerebrospinal fluid, necessary to take several tubes. Tube number 1 for calculation of cells, 1 milliliter. Tube number 2, biochemical analysis of cerebrospinal fluid, level of proteins, glucose, chloride. Tube number 3, 2 milliliters. For bacteriological research of it, tube number 4, after centrifugation and sedimentation, for microscopic examination with coloration by gram and Indian ink. Tube number 5, saved and used additionally if standard procedure not give result. We not get result after primary examination of cerebrospinal fluid of patient. Treatment of generalized form consists of of etiological therapy. Main role in etiological therapy of meningococcal infection belong to antibacterial therapy. Antibacterial therapy start immediately within period of fever plus 3 days of apyrexia for meningococcal sepsis or to moment of decreasing of cytosis less than 30 cells in case of meningococcal meningitis. Medicine of choice for meningococcal infection, usual penicillin. Reserve remedies, chloramphenicol, maybe use ampicillin, or more often in English-speaking countries, using of cephalosporin or third generation, especially in combination with fluoroquinolones. Pathogenetic therapy, syndromal therapy include dehydration, because in a lot of cases will be suspicion of brain edema. Must be detoxification using of glucocorticosteroids, treatment of hemorrhagic syndrome, and symptomatic therapy. So, more rare form of meningococcal infection than nasopharyngitis, meningitis, and meningococccemia, pneumococcal pneumonia, uh, mm, so what I made to say about pneumococcal pneumonia. Uh, I'm very sorry, a long delivering. Of course, I am not about pneumococcal pneumonia, what will be associated with typical clinical picture. I'm about meningococcal pneumonia here. Will be focal or lobar changes, expressed intoxication, and moist rails in lungs. In X-ray will be shadows. What's the risk for this local form? Risk of generalization, transformation to meningococcemia with DIC and hemorrhage. Other variant of meningitis, what may be more often meted in clinical work, pneumococcal meningitis. First of all, source of infection, different patients with various form of pneumococcal infection, usually pneumococcal pneumonia, route of transmission airborne. Practically half of meningitis in adult belong to pneumococcal etiology. Minimally one-third of cases are secondary and develop as complication of otitis, sinusitis, or pneumonia. Mostly this form realized in old people. This form of disease realized in old people or in people with sugar diabetes due to secondary immunosuppression. What's specific of pneumococcal meningitis? Quick involvement of brain substance in pathological process accompanied with development of meningoencephalitis. Very fast appear mono and hemiparesis, oculomotor disorders, and ataxia. From third, fourth day of disease can develop coma status with signs of brain stem dislocation. Pneumococcal meningitis, pneumococcal meningoencephalitis It is a malignant form of disease with very often lethal outcomes. Due to what I again repeat, this form of disease very often realized in people with immunosuppression, with previous long course of chronic diseases what provoke secondary immunosuppression. Cerebrospinal fluid in case of pneumococcal meningitis is typical purulent. What is interesting, very high level of protein and very high level of cells, thousands cells in 1 microliter. And of course, prevalent of neutrophils will be suspected in this clinical for this clinical form too. Steps for diagnostic: same microscopic examination, bacteriological research, with revealing of Streptococcus pneumonia. Serious meningitis, numerous diseases of numerous infectious diseases of central nervous system with similar clinical manifestation and morphology, but will be serious inflammation. Serious and not purulent, serious inflammation, mostly viral etiology for this disease, for serious meningitis. Etiology may be very different. There are acute lymphocytic choriomeningitis, tick-borne encephalitis, meningeal form of poliomyelitis. So a lot of diseases may play as primary viral meningitis. More numerous of secondary serious meningitis when disease start play as complication of primary disease. For example, a lot of acute respiratory viral infection, for example, influenza may provoke serious meningitis, chicken pox, mumps, rubella, practically all herpetic infections as herpes virus directly, as cytomegaloviral or infectious mononucleosis may provoke secondary serious meningitis. Less often, serious meningitis occur with bacterial infections such as TB, brucellosis, leptospirosis, Lyme disease, and yersiniosis. Pathogenesis practically same with purulent, but type of inflammation will be other. Again, will be hyperproduction of cerebrospinal fluid due to irritation of vascular plexus, but here will be direct irritation with viruses, not with the toxins. Clinical manifestation will be same: general signs and meningeal syndrome. What is interesting here, meningeal syndrome less severe. Meningeal signs may be less severe, may be mild form of infection with mild meningeal signs or absence of meningeal signs, but may demonstrate a clinical picture, and same with purulent meningitis. In cerebrospinal fluid, lymphocytic pleocytosis, protein level slightly increased, sugar level normal. Sugar level is normal. Examples of I'm sorry. Examples of serous meningitis, enteroviral meningitis, uh, one of form of tick-borne encephalitis, Lyme disease may provoke serous meningitis, but it is as examples of diseases what may be used for differential diagnosis in case of our today topic, meningococcal infection, meningococcal encephalitis. That's of what I wanna demonstrate today in time of lecture. Thank you for your attention. Be careful and be healthy. Thanks.